Welcome to this morning's symposium on empowering care in cataracts, optimizing the patient journey for better outcome. This is a very symposium on basics. This is to help you get started on some of the devices you may have. To start it off, I'm going to talk about mastering the IOLMaster 700. It is not so much on how to use the device, but more on how to maximize from the IOLMaster printout or whatever printout you need. This is my financial disclosure, and you're welcome to have a look at this book. This book is I've contributed 2 chapters in this book. There's a book on IOL power calculation. It's over 1,000 pages. Well, the IOLMaster is not just a biometry. It can do quite a few things. I use it for biometry, dry eye assessment indirectly. Of course, there is a corneal topography component as well as a retinal OCT. First and foremost, this is the IOLMaster printout. Somehow, coming from an institution and more than 50 ophthalmologists, a lot of us skip the first part, the patient ID. You assume that it is the correct printout for the correct patient, but it may not be so. So it's always good to start off looking at the printout and look at when the date was, when was the measurement acquired. You don't want to use an old printout. You want to use as recent as possible. Alright, there is always this alert box, and I suggest you always have a look at this alert box because it tells you about, it alerts you to the unusual or the IOLMaster measurement. Then of course the ocular status, whether it's post-LASIK, pseudophakic, or unoperated. And then the data, this data is important. I will go more into this. And finally, of course, this is the one we always look at, the IOL power calculation. In my practice, when more than 75% of my patients are toric, I almost always use toric formula. And I suggest that you use toric formula even if you don't put in much toric IOL, so that you know what kind of expected post-op astigmatism the patient might have. This is the old way of printing out the spherical equivalent only. I don't use that anymore. I just use the toric formula. Like I said, whether you use toric IOL or not, it gives you a better, understanding or knowing what the patient post-op refractive outcome is like. Okay, so this is my personal workflow. I almost always have the analysis printout. This is the analysis page. Of course, we have also this printout. Why this printout? I will tell you later. And then the posterior K printout. Alright, this is important because I want to decide whether I'm going to use the TK values or not to use TK values. And of course, finally, the eye, because I use Callisto, which routinely I want to make sure I have a good image of the eye so that I can track. And if I don't have a good image, I always make note of that so that before the patient gets onto the table, I make sure I manually mark the eye. Alright, this is one of the printout. You can see here there's an alert page here. This patient obviously has high cylinder. Please pay attention to that. It is not just here. Let me change this to a pointer. It is not just here. You've got to look at this. High astigmatism, long axial length, asymmetrical axial length, Alright, because it's kind of alert to you whether this measurement is reliable or you need to repeat your measurement. I have 3 ways of looking at it. If you think it's unreliable, you always, the biometrist has been informed, you repeat the measurement. If it's still not reliable and you suspect something is not right, then get a second biometrist to repeat it. If not, then patient come back another day. It sounds tedious, but that's how we do it. This is, of course, anisometropia. Here you can see that the 2 eyes measurement is very different. Alright, when the measurements is very different, again, first, is it reliable? 2, you got to plan the IOL, the 2 eyes. Alright, whether it's monovision, whether it's multifocal, you got to make sure the IOL powers, the IOL you want to implant is available for both eyes. Because sometimes, if it's at the low end, a 6 diopter, 5 diopters, with the other eyes, you may find that you don't have that IOL of that particular model, then you have to start looking for another type of IOL. Alright, this is just to show you the anisometropia, and I always look at this as well, what we call the fovea peak, to make sure that it is an optical axial lens. That means to measure from the corneal vertex up to the fovea. Alright, if you don't see this, then you have to ask yourself, 1, whether the patient is fixating, 2, is there something wrong with the macula? Okay, so almost always it's bilateral, even though if my institution is a public hospital, most of the time we do 1 eye, but I insist on having bilateral to allow for this comparison. Alright, here just to show you this patient, of course this is operated eye, this is a pseudophakic eye, this has no fovea peak, and this eye has a very good fovea peak. Alright, like I said, it may not be that the patient is not fixating, it may be that there's something else with the macula. Okay, so you might want to proceed on to do retinal OCT, or you might want to repeat the measurement. Okay, this is a shallow ACD, and it's important to know this of course, on the slit lamp you may see, but here you want to know, because if you look at it, for example, it's so shallow, alright, we have quite a number of patients, then you have to ask yourself, with the phaco tip, do you need to make special allowance for this shallow ACD? Alright, and the lens thickness here is extremely thick, which means I do femto routinely, femto cataract. I've got to make sure that, this patient femto is going to use quite a little bit of energy, and I've got to make sure that the posterior capsule read by the femtosecond is consistent with the IOLMaster. Alright, you don't want the femto to cut too superficially or too shallow. So in this kind of patient, you may want to use more viscoelastic at the beginning to deepen the anterior chamber so that you can manipulate and do the necessary before you start phaco. Alright? Now this one is of course ICL, you can see the lens here. So for this one you have to be careful. The ICL here, you got to make sure you set to the ICL mode, the phakic IOL mode. But having said that, if you forget to set during measurement, you can always go back and set that mode, because the IOLMaster, remember, measure the raw mode. And even if you don't, frankly speaking, phakic ICL doesn't change the IOL power calculation that much. But it's always nice to know, and it's always help you to prepare for your surgery. Okay? Now this one has a long warning behind. It is important that you look at this, and not just this. Alright, you've got to read the message, the alert, and find out what the system is trying to warn you. Of course, the IOLMaster has a C-topo as well. This is the C-topo of the IOLMaster. It's measured 4 to 5 mm, just the central. It doesn't measure to the periphery. This is a typical astigmatic topo, so all the more you should put in a toric IOL. Okay, and this is a post-LASIK. Once you look at it, you know it's post-LASIK. And if the patient does not give you the history, or if you ask the patient and the patient doesn't give you the history, this is a good way to suspect that the patient has LASIK. Alright, and therefore you use the LASIK formula instead. What next is the macular screening. This is what we call good fixation. You have the fovea peak. Alright, and this no fovea peak. Is it poor fixation? I use it to screen macula. In fact, sometimes I don't even do retinal OCT anymore. In the past, I routinely do it because I have a lot of premium IOL in my practice. But for example, this one is a thickened fovea. This is from IOLMaster, not retinal OCT. Alright, but lamellar hole, macular edema, diabetic macular edema, and of course, retinal detachment. So pay attention to this because it tells you a lot more. If you are solo practice and you find retinal OCT too expensive, the IOLMaster is good enough to help you decide and help you manage this patient and screen this patient. Of course, if you have any of this, please be careful. You have to counsel the patient properly, or you may want to proceed on with retinal OCT. Of course, reference image down here, I make sure I have this because I use Callisto. We are using Callisto. This is important because without this, you cannot align the eye intraoperatively with Callisto. If you have this, well and good. I'm very happy because then I do not need to manually mark the eye. Okay, so this is the picture image. Again here, I will look at it to make sure the vessels and everything are well captured. The limbus are well captured because Callisto needs a good, well-defined limbus as well as good vessel. This is not well captured, then the Callisto is going to be more challenging. Alright, so as you can see, the preoperatively IOLMaster is not just a biometry. It gives you dry eye assessment that is from the standard deviation of the K reading. If the standard deviation is 0.05 diopters or more, you may want to suspect that the patient has significant dry eye. It's a biometer. It's a good corneal tomography. Alright, it gives you a good retinal tomography. So you see, there's a lot you can do with the IOLMaster. So thank you for your attention. Any questions? Well, if not, then I ask the next speaker, Cleary, to come and give us a talk on importance of topography screening in cataract surgery.
Great. Thanks very much. I'm thrilled to have the opportunity to be a part of the faculty here. And I'd like to run through some of my thoughts regarding central topography on the IOLMaster 700, which I think is a really fantastic tool for getting your patients through the quite hectic clinic workload. This one's not working. Oh, hang on. Disclosures. So I'm a cornea, cataract and refractive surgeon in Melbourne, in Australia, and when I'm seeing my cataract patients, there's so much information to synthesize. We've got a patient in front of us, we're trying to get a feel for their personality, their lifestyle, and then we have an array of testing and an array of scans. We've got to put all of this information together, we've got all of this data collection we're putting this all together to make a recommendation and a selection for an intraocular lens. When I've got my patient in front of me, so here's my cataract patient, she's a bit worried because her vision's blurry and she's heard about all these different lenses and her neighbour had a multifocal. So I tell my patients that we're going to run through options, we're going to choose an intraocular lens, and we're going to choose the lens which is the best match for their eye and for them as a whole. And I want to, at this first visit, set expectations, particularly in the context of coexisting eye disease. And ultimately, I want a happy patient. I want 6 happy. It might not be 6, but I want 6 happy. So we're going to spend the chair time pre-op, not post-op. But if we're going to do that, we need to gather as much information as we can. We don't want to be looking at some scans a week later when we're choosing a lens and find out, actually, this patient has an abnormal cornea and they're not a candidate for a premium lens after all. So this is where the central topography is going to come in. So among all of these tests, this is a useful screening tool so that you can start planning the direction you'll take the conversation with your patient. So we're going to look at this analyse page, like Dr. Fam said, and we're going to use this as a rapid qualitative assessment of the central corneal shape. A bit like when you have a quick look at your macular OCT. You're not looking at the central macular thickness there, you're not looking at a number, you're looking at the shape to see, does this look anatomically normal? And I can access this within Forum. So in my practice, I'm able to view the macular scans, the retinal nerve fibre layer scans, and my central topography within Forum, so I'm not going through multiple softwares to access the information. And so if the corneal shape looks normal, and of course we've got the colours here, so the colours are very useful. It's easy for us to look for outliers and patterns with different colours. If this looks pretty normal here, then I'm going to have a good idea that this patient will be a candidate for a premium lens. And having the bilateral scans, bilateral analyse page open is also really useful as well, looking for the difference between eyes. So this is a patient I saw late last week who was very interested in a multifocal lens, but clearly those colours are telling you that something is wrong there, and this guy had undiagnosed corneal ectasia. So it already means that you're going to direct the conversation in a certain way. Now I want to share a case study. This was someone who was referred to me. They have already had their cataract surgery, but they've had a poor outcome after their surgery. So he's 77 and he was referred to me with corneal decompensation for a DMEC. Now unfortunately he is the uncle of an ophthalmologist colleague, and another colleague did a routine left cataract surgery. Nothing exciting about the surgery, but afterwards he had postoperative corneal edema, which did not resolve whatsoever after 12 weeks. So he was 6'24". This is a guy who's got a truck license, and he was pretty unhappy because he was expecting a pretty good result. So when the referring surgeon then looked at, why did this happen? Surgery was pretty routine. He was trying to figure out why things had gone wrong. He could see no corneal disease on the patient. There was no Fuchs in the fellow eye. Surgery was normal. There was no decimase detachment found on anterior segment OCT. Were there any clues on the pre-op imaging? And in fact, yes, there were. So I got access to this patient's pre-op central topography. And you can see that this is not a normal scan. We're seeing the cornea is flatter and there is irregular astigmatism. So if you see an abnormal scan like this, and in fact the bilateral scans were not quite right, but it was worse on the left eye, which was operated, this should be a trigger to look a little bit deeper. So my patients all have corneal topography with either a Sirius or a Pentacam, but this should be a trigger at that point to have a look at those scans. And this clearly is abnormal. On the axial curvature map at the top left, we can see there's irregular astigmatism, and the corneal thickness map is screaming out at us, this dark blue here. This patient has a very thickened cornea on the left side. And then, let's go back to the IOLMaster. We have a 613 micron cornea on the right and 761 on the left. So this was all there beforehand, but there is so much information for us to synthesise in that first visit. Of course, we're going to miss some numbers here. So this is really an opportunity for AI to be able to tease out these things. We get a warning if axial length is different. but we don't get a warning for this. And there can only be so many warnings. I think in the last presentation we saw a whole block of text with all the many warnings for an atypical eye. I think if there's too many warnings, we perhaps don't pay attention. So for this guy, cataract surgery did not meet his expectations, and the pre-op scans did show a problem there. So we could have predicted a worse outcome for this patient. After his DMAC, eventually he achieved good vision, 6.6, but he did have a hyperopic refractive outcome once things had all settled. So what perhaps could have been done differently for this patient? Well, maybe he could have had the right eye first and that could have settled, and then he could have had the left eye treated. He could have had a DMAC triple, and the lens planning could have aimed for a myopic outcome, so hopefully he would have come closer to planar. So it's all about setting expectations. And, you know, this is not just my experience. This has been published, the good agreement between the central topography and our shine fluid imaging. And in this particular paper, this was really useful. They looked at different observers, looked at the agreement between the two devices, and they also made decisions whether, based on the central topography from IOLMaster, they would recommend a premium lens. And there was agreement between around 75 to 97% between the observers and the devices. So just showing that there is some evidence that this is a good tool for your premium workflow. And you can download from the Zeiss website this compendium, which will give you some nice examples. So here's my compendium, just a few examples before we wrap up. Flat keratometry. So I'm just showing you the central topography and then the agreement with the top left axial curvature map. So here's someone with flat Ks, but otherwise, you know, they're pretty regular and it's a fairly normal cornea. Here's someone with steep Ks. They haven't had prior surgery. So the colour coding works really well to spot outliers. Pellucid, it often picks this up really well. It's often in the central cornea, it's fairly regular right at the centre. So this is someone that I'd probably still be using a toric lens. But the importance of this is identifying a problem, and then you're going to have a discussion about refractive outcomes and, you know, indicating to your patient, look, you know, my goal is to hit the target so you have excellent vision without your glasses. But given these changes here, the chance of you having an error is a little bit higher. So it's not just about the premium lens, it's the chance of a refractive error post-op. And then screening for previous laser refractive surgery. We know lots of patients kind of forget that they've had treatments done. This is screening out of this red pattern here. And then on the pentacam, we can see a classic post-hyperopic refractive pattern. This is a post-LASIK ectasia. Here's someone who's worn contact lenses for years, so very irregular shape here on the central topography. And then this one was interesting. Here's a patient where you can see there's some asymmetry when you compare the two eyes. And it turns out they've actually come along for their assessment with a contact lens in their right eye and they forgot about it. So this was the scan with the contact lens in. And when we actually look at the scleral image closely, you can just make out the edge of the contact lens there. So we've had them remove the contact lens, come back a couple of weeks later, and there's a really big difference in the keratometry there. So if we missed that, we would have ended up with an unfortunate refractive outcome. And then another one here, this was someone who came to see me for multifocal intraocular lenses, and they have a large corneal nodule, and so the central topography couldn't even be captured. So we know that there's a problem here, and for this patient I'm going to remove the nodule and then we'll make plans for their surgery. So I hope this is useful to share that it's really, really helpful to use the central topography as a screening tool. I think you get a lot of information from the topography alone, but it should be a trigger if it's abnormal to carry on and look at your alternative topography imaging to help set the expectations for your patients, for premium lens, refractive outcomes in general, and also the selection of your formulas so that we can set the right expectations for our patients. Thank you.
Thank you. Any questions? Is that drawn by you?
Yes.
Very nice.
Yes.
No pathology?
Just a cataract. She'll have a premium lens.
Just one question for you. How often do you have to use full full-size cornea topography on top of your IOLMaster?
All of my patients have the full corneal topography, so they come along for their cataract assessment and have IOLMaster, Pentacam or Sirius, depending on the practice, and their macular and retinal nerve light delay or OCT. So it's a long appointment, and I do look at both in all of them. In fact, that's not true. If the IOLMaster is suggesting I use a non-toric lens, then I don't have a close look at the topography because it's going to make less of a difference. I also like to just make sure that the axes are agreeing. So when I'm planning a toric lens, because like you, I have a high percentage of toric use. This year I've looked at my data, I've done 74% of my cases have toric lenses. So I'll always look at the axis. I'm not really interested in the power for the keratometric astigmatism exactly agreeing because they're different devices, we see different numbers there, but I'd like to see the axis agree. And for example, say the IOLMaster says 50 degrees, sometimes I see a slight variance in the axis, but I will look at the shape on the corneal topography, say from Pentacam, and as long as I can see that the general direction of the astigmatism agrees, then I'll be happy with that. So I don't have a strict cut-off, it must be between 10 degrees of the two. I'll assess the shape. But I do it for all my patients. That's our workflow now. I think that if you're in a very busy practice, you could have an argument, and if you have your staff trained if the central topography looks nice, perhaps you could consider skipping the secondary imaging.
Okay. Any other questions? If not, thank you very much. On the next speaker.
Good morning, everybody. Thank you very much for the introduction. I'm talking now about the Artemisia tree, which is kind of odd if you think about talking about this at a science meeting. But the thing is, it is more or less a gold standard in trifocal technology. It was a pioneer, and the long-term data are very important. And I'd like to share with you some of the points here. These are my disclosures. So it is on the platform of a plate haptic hydrophilic acrylic intraocular lens, the monofocal, the toric, the bifocal, the EDOF lens, the Artenara, which is not available in all the countries which are represented here, and the trifocal and trifocal toric version. And we looked at this lens several times from different ways, also looking, for example, on the optical bench or analyzing the optical pathway, and compared this also to other lenses. An optical bench nowadays looks like this. This is a machine, here the one from Trioptics, which analyzes the image quality and a lot of other features of an optic. You can visualize the optical pathway of lenses and also look at the areas for near, intermediate, and far, and what kind of image is presented on the retina. You see here the Artemisia tree, the panoptics, and the fine vision lens. You can, for example, see here the different distribution of light to near, intermediate, and far, as you can see here, the foci. And if you compare, for example, the through-focal scan, and you align these lenses with each other, you can see, for example, that the Artemisia tree is very good in the distance. Here at 21 diopters, the MTF is very, very good, and also in the other areas. If we really look into the image quality, and we look at the far and near focus, and there are two terms like the MTF and also the stereo ratio is described if an optical system is good. It's quite interesting to see that still the good old laser is outperforming the panoptics and the POTF, the fine vision, on these examinations. So this is something I think we should remember. We have also published that this paper here. So looking at the diffractive pattern and the combination of the two diffractive lenses, which are more or less a trifocal is made of, the near edition and the intermediate edition, we learned that the way the diffractive profile was done, is a kind of special thing. It depends really on the distance between the rings, on the height, on the steepness, and so on. There are a couple of features where you can manipulate the incoming light in a way. For example, also with the smoothed edges, to reduce stray light and reduce side effects, which is quite important. We worked quite a bit with IOLMaster and published a lot of papers, clinically and laboratory work. And one thing which is also quite important, especially on the long run, is how good you hit the refraction and how good you take care of astigmatism. Steve Schellhorn has actually published quite a nice paper on the impact on residual ametropia and trifocal technology on patient satisfaction. And there is a zone, you have to stay within a zone of like plus minus a quarter or half a diopter, and within this zone the patient will be happy. If you are outside this zone, you will see that this will be one of the main reasons for dissatisfaction in unhappy patients. And especially multifocal and trifocal technology is quite intolerant, even sometimes to small amounts of ametropia, especially astigmatism. We can actually pin that down to the fact that for every quarter of a diopter of residual myopia, there's a 25% increase in dissatisfaction, which is quite important to see. And if we go to the astigmatism, all these comes into play if you have more than 0.75 diopter of residual astigmatism. So better actually target for less than half a diopter to have very excellent outcome. And that's not so easy because we have to know that we have quite a big number of patients, normal patients that come into our clinic that have some kind of astigmatism which may be relevant for our planning. So we always have to keep that in mind. And then if we use a toric platform, we really should be sure that we don't have any misalignment, because with a small amount of misalignment you already reduce quite a bit the effect of a toric IOL. Well, nowadays we have a lot of tools helping us to calculate a toric IOL. You see here I made a video what we do when we put the data in the forum for Callisto toric IOL calculation. And this works quite nice actually. And even though in older times we used ink marking and all this kind of stuff, it still kind of worked. We get a completely different type of precision here. And frankly speaking, 20 years ago, we didn't really do the clear lens extraction with multifocal toric lenses in younger patients. This is something that we do more or less the last couple of years, and there we really need a very high amount of accuracy. And it's pretty easy to do and self-explaining how you walk yourself through the setup on the screen to calculate the lens. And as you have seen here, I think we can skip that now. If we look about the long-term stability, especially also the rotational stability, I have some cases and also some publication here. So this was a patient, fairly young, has a complicated cataract after high-dose steroid therapy, subcapsular cataract, and even though vision was not really bad, the patient was very annoyed, especially by the light, the glare. And we did the calculation and the corneal tomography and IOL calculation, and in this case, toric lens was implanted. So the outcome, hitting exactly the target, was excellent. You see here, post-operative uncorrected distance acuity minus 0.16 logMAR, which is 1.6, almost 2010. So she was very happy with that. This is very important. And then 6-7 years later, she came in the clinic and still was very happy. We see a little bit rotation. If you look at it, 6 degrees sounds quite a bit, but if you have such kind of rotation over time, the eye adapts and the brain adapts to that very easily. These patients never complain. You don't go here and try to re-rotate this stuff. This is completely stupid. And you see also here very nice the focus curve being over 1.0 or 20/20 over a range of 3 diopters or 3.5 diopters, as you can see, and still being extremely happy. So these kind of patients we can create, and we can be sure that they will function over time. We then actually looked at several patients from us, and we published that in the Journal of Refractive Surgery. The average follow-up was 5.5 years, but we had follow-ups up to 10 years. We very carefully measured the IOL position, especially the axis. with the pentagram IXL wave and the retrolumination mode, as you can see here. And then when we just look at the basic parameter, you can see quite nice outcome. So more or less uncorrected distance, uncorrected intermediate and near visual acuity was all around 0 logMAR, even after this time. There was a slight shift to myopic refraction, as you can see here, but on average the patient was very happy with that. And if we look at the defocus curve, we have a very flat and straightforward defocus curve here of our patients, even after that long time. Looking at values for halo glare, we have a special simulator for that. We're talking here on values on a scale from 0 to 100, and having values around 10, 20 is pretty good outcome for a trifocal intraocular laser. So we come to the conclusion that the patient with the multifocal IOLs, of course, we have to satisfy by hitting the target. And you heard Angor's lecture about the IOLMaster. You have the tools to do that, and that impact of residual ametropia can be one of the most important reasons for unsatisfaction. The correction of postoperative astigmatism is very important, and there we see a very good long-term outcome of the Atelisa tree toric. And if we look at the whole platform that we have combining the Atelisa tree, the Atelana nowadays, and Atelara, we have quite a bit of choices in order to have an individual approach for our patients. So thank you very much for your attention.
Thank you. Any questions on the floor?
Thank you. What is your rate of having to do a laser enhancement after putting in a trifocal?
I have to say that we haven't done any laser touch-up the last 4 or 5 years. If we have a problem, maybe re-rotation could be a problem, that we have to rotate an astigmatic correction. Once in a while we do a supplementary add-on lens if we are, for example, in a post-LASIK patient, like 1 diopter or 1.5 diopter off, mostly in the hyperopic range. So there we prefer the touch-up laser. Maybe every 2 years, one maximum. But if you work with the platform, if you use a CT Aspina as your basic lens for monofocals, and then the other lenses for premium, then you have a very good idea about the outcome based on the IOLMaster data, fine-tuning and optimizing, individualizing your A constant. And then you can really stick very nicely with this. Never really has a lot of outliers.
It was a very impressive presentation. When do you usually do the capsuloptomy in this treatment?
Yeah, that's a good question. I usually do YAG laser if there is a posterior capsular pacification, which is not really after 3 months. Yeah. There are some refractive surgeons that routinely give the patient an appointment after 3 months for YAG laser treatment. I wouldn't do that. First of all, it's still the sensitive period that you can still create some cystic macular edema. And the other thing is, if there is nothing to YAG laser, I wouldn't do it. Yeah. You can sometimes have situations that you have posterior capsular folds, which are annoying, and where you have the impression that this contributes to some problems. Then of course you can do the laser, but not before, let's say, 4 to 5 months after surgery, in order to prevent any macular issues.
Thank you for the excellent presentation. So my question is, so your threshold of putting a multifocal toric is cylinder of 0.75 diopter, and then you put a toric multifocal in all cases, is that correct?
Yeah, I usually look at the situation and more look at the expected postoperative astigmatism. Even though on the IOLMaster you have whatever 0.81, which is below 1 diopter, I would consider if I go from 12 o'clock, I may induce astigmatism, and if I go from temporal, I may not reduce it. So I would go for a toric version if the lens is available.
So basically, you're looking at the outcome aiming of less than 0.5 diopters of astigmatism.
Yeah, as much as possible. Yeah.
Yeah. Thank you very much.
Any other question? No, one question. You expect one question for you. You expect the same for Ilana, because now we are migrating to Ilana instead of Lisa.
Yeah, I would expect the same. We may have a little bit different capsular performance of a hydrophobic C-loop type lens. So maybe yak laser is an issue which is asked a couple of years later with this type of lens. And as it's aberration neutral, I think the lens will be also forgiving in several aspects. So I expect at least these values even better outcome with the Ilana on the long run.
Okay, thank you. We'll move on.
Good morning, everyone. Thanks for the invitation to share my experience using latest digital technologies in my practice. This is my financial disclosure. There have been many studies to analyze the corneal astigmatism in cataract patients. This is one of the large-scale studies in China, showing that 39% of the eyes had corneal astigmatism higher than 1.25 diopters, for which toric intraocular lens have been proven to be a good option at the time of cataract surgery. In my hospital, we have 8 to 10,000 cataract patients every year. 1/3 of the patients of the surgeries are implanted with toric intraocular lens. Before we had the EQ workplace, the use of toric intraocular lens was a complex process. The pre-operative and intraoperative steps were time-consuming and brought to human error, which would affect accuracy and efficacy. However, with the help of EQ workplace, which has significantly increased our work efficiency, we can save more time and treat more patients. The EQ workplace has many advantages for refractive cataract surgery. One of the most significant improvements is that it can transport data automatically, thereby minimize human errors. As we know, the IOLMaster 700 can measure the posterior corneal surface, and the total calorimetry can be used in the EQ workplace to calculate toric intraocular lens directly without the need of third-party software or an online calculator. In addition, the BERT-TK toric formula on the platform helps get pure refractive supplies. We can access data remotely from home and by using EQ workplace, which connects directly to crystal eye to perform our surgical planning for anywhere preoperatively. This is a case that leads to implant toric intraocular lens. When starting the surgery, all relevant assistant functions are already reset. The insertion, capsules, and target axis for toric intraocular lens are directly displayed through the EQ workplace to crystal eye. So, saving the time and making the surgery more precise. and the postoperative visual outcome is great. Published study shows that the digital cataract workflow is more efficient and provides slight cost saving compared to manual workflow, especially when planning for toric intraocular implantation. Let's look at two cases. Case 1 is a high myopia patient. Over the past year, the patient's visual acuity had decreased significantly due to cataract, and she wanted spectacle free after the surgery. Also, she has extremely high myopia. Fortunately, fundus examination revealed relatively normal condition. This patient had regular corneal astigmatism. We performed for the second laser-assisted cataract surgery and implanted anti-laser 3 toric intraocular lens, also with capsule tensioning to enhance the capsule bag stability. In this case, we use the EQ or press to plan the target implantation axis, which was implanted to crystal eye directly. In addition, we use the latest model of catalyst for the second laser device to perform corneal marking of the toric axis. What's the two measures showed high accuracy and consistency. This is the corneal mark by the laser. Usually, this corneal mark is about 0.5 millimeters. Three weeks postoperatively, the patient achieved good near, intermediate, and distant vision. Astigmatism correction yields superior visual outcomes, and the OPD scans results also showed excellent visual quality. Case 2 is a patient that needed ICL extraction followed by cataract surgery in the right eye. This patient also wants full range of visual after the cataract surgery. We decided to implant anti-laser 3 intraocular lens. It was noting that IOLMaster 700 misidentified the anterior surface of the ICL as the anterior surface of the lens, resulting in error LCD measurement data. A good surgical outcome depends on the high accuracy of intraocular lens calculation formula. When we noticed this interesting phenomenon, we performed a study to investigate the influence of LCD measurement error caused by ICL. We found that the measurement error of LCD and the LT caused by ICL in primary myopia eyes doesn't exert a significant influence on the prediction accuracy of IOL power calculation formula. In this case, we use the ESCS IOL calculator to calculate the IOL power. Finally, we choose one the output to implantation. At that time, we still have lost the EQ press. 1 month post-operatively, this patient achieved good full range of vision, wide platform in defocus cover, excellent refractive outcomes, and visual quality. In conclusion, a digital cataract workflow is more efficient and reduces staffing costs compared to a manual approach. The biometric data from the IOLMaster are automatically transferred to the EQ workplace, streamlining intraocular lens selection by auto-populating calculation fields, and minimizing human error. Private haptic trifocal intraocular lenses demonstrate excellent capsule bag stability and deliver satisfactory visual performance in cases with high myopia. Thank you for your attention.
Thank you. Any questions?
I have a question for you. I realize if you're using IOLMaster and Callisto, you transfer the data from IOLMaster to Callisto, and therefore remove the requirement to manually mark the eye.
Automatically.
Yes, but I notice you manually mark the eye. You need to manually mark the eye.
Just change from automatically. No.
Any other questions? The other question I have for you, have you used the old IOLMaster 500 or earlier version of IOLMaster?
All of the patients use the IOLMaster 700.
But do you have the older IOLMaster before 700?
Yes, we have used it several years ago.
Okay, so my question is, do you find out the penetration of IOLMaster 700 compared to the older IOLMaster? How much better is the IOLMaster, the swept source velocity?
We still have not this compared. About grade, you can grade 4, we can get.
I see. Any other questions? If not, thank you very much.
Thank you.
So proceed on with the next speaker.
Good morning, everyone. Thank you for the context for inviting me. Today I will present a case with the title Seeing Beyond Today, Preventing Tomorrow's Ocular Challenges. I have no financial disclosure for this presentation. Let me start the presentation with a quote from Benjamin Franklin. An ounce of prevention is worth a pound of cure. I think this is very relevant for us nowadays because refractive cataract surgery has never been more advanced and more complex than today. We have entered an era where there is many tools at our disposal, from diagnostic tools until surgical instrument that robust the accuracy and the safety level of the surgery itself. But there is still some question. Sometimes we will find a more complex and more challenging cases than usual. Can we get the same optimal result as usual? Can we maintain the quality for the long term? And are there any potential complications waiting for us in the future? So I will share two cases today. First case is 44 years old female with high myopia and moderate to high astigmatism with cataract nuclear sclerosis grade 3 with pre-op visual acuity for the right eye is 0.1 with minus 22 cylinder 2 and 0.08 with minus 20 for the left eye. For the tomography of the cornea, we can see that there is a regular astigmatism with the corneal high order variation 0.06 below the 0.3 and the normal spherical aberration. So the left eye show the normal corneal astigmatism and the high order aberration is below the 0.3. So the patient is still available using the multifocal eye. When we see the result from IOLMaster 700, we can see the axial length for the both eyes around 26 mm with total keratometry for the right eye is minus 2.6, and for the left eye is minus 2.2, with the normal angle alpha and angle alpha. After we discussed to the patient choose Atelisa tritoric with +9 cylinder 4 for the right eye and +10 cylinder 3.5 for the left eye. So this is the surgery. I use a 2.2 millimeter incision with the quarter machine. I start the operation with the not fully dilated pupil, but from the pressure from the irrigation, we can see the anterior chamber is so stable. Before I implant the IOL, I always polish the posterior capsule and also anterior capsule to prevent the posterior capsule ossification. After this, I implant CPR before I implant the Atelisa tritoric. After the CPR implant in the back, I put Atelisa tritoric with guiding from the callisto eye. I can rotate and implant on axis without worry of the rotation because the plate haptic is so stable, and I can rotate for the both direction. Okay, thanks. And this is the post-op perfection for 1 month. The result is excellent. The case number 2 is 31 years old female with high myopes and high astigmatism with sclerosis grade 2 to 3 with pre-op refraction 0.4 with minus 11 and 0.5 in the right eye, and the left eye 0.5 with minus 13 and 0.4. The tomography of the cornea is still regular astigmatism. The corneal high order aberration and striatal aberration is normal. So the left eye shows the normal values. And let's see the IOLMaster 700. The axial length was around 28 millimeter for both eyes. I do the IOLMaster laser when we still not have a K before. So the astigmat K is minus 3.5 for the right eye, and for left eye is minus 3. And then I calculate with a Gerd toric calculator with predicted PCA, and the patient choose Atelisa tritoric with +1 cylinder 5 for the right eye and Melino and cylinder 4.5 for the left eye. This is the operation I have done with the callisto before. So I do a manual marking. I make a capsular axis a little bit bigger, around 5.5 millimeter. And then I implant also the CPR before I implant the Atelisa tritoric. Nowadays, in most of all cases with high myopes, I always implant the CPR before I use implant the refractive area. For the post-op refraction, after 1.5 years, the visual acuity is still excellent. What I want to highlight with the 2 cases is first I use a plate haptic IOL and then additional CPR for the case. What I'm concerned is first is the centration. We know that the myopic eyes increase the tendency of inferior decentration, and we can see from the graphic the black dot plate haptic multifocal IOL has minimal decentration compared to C-loop haptic in myopic eyes. We know that the decentration more than 0.4 in multifocal IOL is significantly reduce the optical performance of the multifocal IOL. The total high order aberration in myopic eyes of the plate haptic, the orange one, is the lower than C-loop multifocal, either in the 6 mm or the 4 mm pupil diameter. And the plate haptic toric IOL more susceptible to intraocular trefoil aberration caused by rotation, and then intraocular coma aberration increased by tilting the IOL. So the next I want to prevent is anterior capsular contraction syndrome, or ACCS. It is characterized by the capsular ringing and the fibrosis leading to decentration and tilting of the IOL. We know that the incidence of the ACCS range from 1.4 to 14%, with the most cases occurring within 3 to 30 weeks after the surgery. It occurs because the imbalance of the centrifugal force of the sternum and centripetal force of the lens fiber from the edge of the capsular axis area. In high-risk patients, especially PAX or high myopes and RP, the incidence will increase up to 30% and can develop until years following the surgery. We can see even the low grade of ACCS can induce the night glare, and for the advanced stages, it will induce a high order aberration and will decrease the visual acuity, leading to due to the IOL decentration or dislocation. So the prevention factor I want to tell is the use of the plate haptic IOL and the implantation additional CTR in the high myopes or the high-risk patient. We know that the CTR will enhance the rotational stability of the toric IOL, especially in the early post-operative period, especially in high-risk patients like high myopes. A CTR also will prevent a Mandelbrot effect caused by the posterior capsular striae due to the disproportional lens back size and the IOL sizing. This effect, this Mandelbrot effect, will induce the halo and glare for the patient. So let me show the illustration that I made. We know that the C-loop haptic doesn't give the uniform stress to the capsule, rather than the plate haptic has a 4-point fixation. By using the CTR, CTR gives you the uniform capsular stress and prevent more anterior capsular phimosis. And also the CTR will promote the PC optic apposition, so the effective lens position is getting faster and delay the incidence of the PCO. We can see that Zhang et al. On the left, the loop haptic has a final apposition around 3 months, but in the plate haptic is more faster, around 1 month. And then I try to evaluate my personal data. When I use the plate haptic IOL and CTR, the final apposition is getting faster, around 1 week. So the effective lens position is better, and the stability. And after I follow up after 1 year, this is my personal data last year, I have never found ACCS on all my premium IOL, especially the high risk patient. And the rotation degree is also good, below 4 degree for editor B and 3 degree with Atelisa tritoric, despite I haven't a Callisto before. And for the take-home message, plate haptic is superior in rotation stability and centration, especially in myopic eyes. The combination plate haptic and CTR will promote better PC optic position. And please be wise, because we know that the prevention is more than a cure. Thank you for your attention.
Thank you. Regarding your first case, I find that the refraction is disproportionately higher than the axial length. Because I think the axial length is only 26, I would expect the refraction to be probably -5, -6, or something like that. Perhaps you could explain why he was -22.
I think, yes, that's disproportional from the refraction and the biometry. The grading of the cataract is grade 3 or grade under grade 4. So I think the refractometer result is not available. So my refractionist is trying to correct as high as he can. So I'm sorry, maybe that's not really reliable the refraction.
Any other questions? So what's your cutoff for CTR now? Is it 26 mm or?
Yeah, I do all CTR in 26 millimeter above. But I also do CTR below that if I found maybe a lens thickness is so big, more than 4.5 millimeter, or other high risk patient, also I use CTR.
Okay. No more questions? Thank you very much.
Thank you.
Okay, thank you very much for the introduction. Before I start, I would like to thank Zhang for inviting me today. From now on, I'm gonna talk about my experience with the new at Atlanta, as well as combining at Atlanta with lisatory toric. I'm calling this approach ELISA. This is the last presentation in this section, so I'll try my best to be last but not least. Okay. To put things into perspective, I have so far implanted about 15,000 multiple IOLs from diverse manufacturers in my private practice, of which more than 8,000 have been from the Lisa family. Today, I'm going to present you a retrospective analysis of two study groups. Group 1 comprises 34 patients implanted bilaterally with Atlanta, while Group 2 consists of 7 patients implanted with Atlanta in one eye and lisatory toric in the fellow eye. Patients were followed up at 1 month and 3 months, including monocular uncorrected distance visual acuity and binocular visual acuities at distance 80 and 40 centimeters. In addition, my technicians performed monocular and binocular defocus curve measurements. Finally, I evaluated prompts in study group 2. Okay, looking at the preoperative demographics in the bilateral at Atlanta group, the range of patients was quite diverse, from extreme minors with axial lengths of more than 30 millimeters to hyperops. In group 2, you will instantly notice the reason for choosing a toric IOL in one eye. Mean corneal astigmatism in that sample was 0.86 diopters. I routinely check for potential astigmatism preoperatively, and at lisatory toric is my gold trifocal toric IOL due to the torsional stability and my long experience with this lens. The vast majority of my toric patients get 1.0 diopter or 1.5 diopters cylinder IOL, in my opinion. Any potentially remaining corneal astigmatism should always be corrected with a low cylinder power toric IOL. Okay. Uncorrected bilateral visual acuity results for distance 80 and 40 centimeters were excellent in group 1. At the post-operative month 3, all 18 examined patients had uncorrected distance vision of 0.0 logmar, 83% had intermediate vision of 0.1 logmar or better, while near vision was even better with 94% reaching 0.1 logmar or better. Based on the clinical outcomes, I can confirm that IOLMaster bilaterally provides excellent full range of vision to my patients. In group 2, all patients had binocular uncorrected visual acuity of 0.1 logmar or better across all 3 tested distances. That is distant, intermediate, and near distance. With regard to refractive outcome distribution, all patients in group 1 were below 1.0 diopter at 3 months, with 69% being within 0.5 diopters. In group 2, 79% were within 0.5 diopters, while all fell within 1.0 diopters. In patients with bilateral IOLMaster implantation, there is a broad depth of focus as seen in the binocular defocus curve in this graph. This excellent result is even better, especially in the range from minus 1.5 diopter to minus 3.0 diopter for the binocular defocus curve. As you can see by green line in this graph, the range above 0.2 logmar for study group 1 is about 4.5 diopter, which is an excellent range. In study group 2, you can see that at IOLMaster, you can see like pink line in this graph, has a flatter and better performance than at Lisa-3 toric. You can see orange line in the range of minus 1.5 diopter to minus 2.5 diopter. This can be explained by the improvements to the optical design at IOLMaster with more light distribution to intermediate and near distance. The binocular summation effect, purple line in this graph, is in full play here, and the binocular defocus curve looks very similar to the one in group 1, that is at IOLMaster bilaterally. Moving to the final part of my presentation, I was particularly interested to look at subjective patient-reported outcomes and decided to use the CAT-Quest-9SF. This survey is concise and brief, which fits perfectly into busy private practice like my clinic. All 7 patients completed the questionnaire with an average follow-up of 9.6 months. 6 out of 7 patients faced no difficulty in their daily life, with only 1 patient mentioning some difficulty. I remember it's a daylight glare. Okay. So all patients were fairly satisfied with their vision. Almost all patients also reported no difficulty for reading newspapers, recognizing faces of the other people, walking on uneven surfaces. Finally, all patients had no difficulty at all when reading subtitles at television. Yeah, coming to a conclusion, I can confirm that bilateral IOLMaster provides patients with full range of vision. In patients where one eye requires toric implantation, at Lisa Tori combining with Elana, the so-called ELISA approach is a safe and effective way. And finally, in both the groups, patients benefit from binocular summation effect with very high levels of patient satisfaction in the ELISA group. The limitation of the presentation are that the study group sizes are different and that I was not able to measure and compare prompts for the bilateral and ELISA. Thank you for your attention.
Thank you. It's a very impressive result. Any questions from the floor?
Yeah, I have a question. Do you implant, what do you choose for the dominant eye? Elana or ELISA?
Yeah, I think the dominant eye or non-dominant eye is now important, but important thing is whether or not there is estimates, Korean estimates. So yeah.
Any other questions? I have a question. Based on your infocus curve, would you therefore propose to aim for minus half a diopter myopia side because the distance seems to be still very good to aim for minus half a diopter and you will increase your near range as well?
Very near vision,
Yeah, I mean, can you show your infocus
Okay.
curve?
Elana bilaterally.
Yes. You look at the curve. At half a diopter hypo, you are seeing almost 6 so we propose therefore in the patient with half a diopter myopia so that you have even 4.5 diopters of near vision without compromising your distance.
Okay, so it's very good question, but it's very difficult. So please give me think about that. So I'm gonna tell you later. Any question?
Any other questions? Maybe ask, do you find the patient with this kind of focus curve?
Yeah, I think it's very nice, the focus curve, and I also think that the ELISA approach is quite nice, especially now when we don't have a toric version of the Elana, what can we do? And as these optics are pretty much the same, apart from slight differences, I think it's an ideal thing to do a mix and match in order to apply both technologies. So I think it's a very smart approach.
Thank you.
Really good.
Thank you very much.
No more questions? No more questions, I think we shall end. We are very early, but I think we shall end go for coffee break. Thank you very much.